Hello everyone, my name is Fatima Habib, and today I'm going to be talking about if cancer risk is related to low-dose ionizing radiation from cardiac imaging in patients after acute myocardial infarction. Having a look at our overview of our presentation today, first we're going to be talking about if low-dose ionizing radiation from cardiac imaging after acute myocardial infarction leads to an increased cancer risk. How we can use the hospital discharge databases to build study cohorts and conduct statistical analysis. During the results, we're going to be talking about how 12,020 incident cancers were detected during the follow-up period. And lastly, we will be concluding how high levels of low-dose ionizing radiation from cardiac imaging leads to an increased risk of cancer. Starting off with the first part of our presentation, does low-dose ionizing radiation from cardiac imaging after acute myocardial infarction lead to an increase of cancer risk? So, it's interesting that studies involving atomic bomb survivors have documented an increased incidence of radiation exposure. Similar risk estimates have also been reported among workers in nuclear plants. In the past 6 decades, though, since the atomic bomb explosions, most individuals worldwide have had minimal exposure to low-dose ionizing radiation. However, the recent increase in the use of medical imaging and therapeutic procedures involving low-dose ionizing radiation has led to a growing concern that individual patients may be at a risk of increased risk of cancer. Yet, even with its associated risks, cardiac imaging has become more and more common in medicinal practice. Newer types of imaging procedures use higher doses of low-dose ionizing radiation than those that used in more traditional procedures previously. So this study aims to discuss the risk associated with patients exposed to low-dose ionizing radiation from cardiac imaging and therapeutic procedures, and aims to directly link cumulative radiation exposure and cancer risk after myocardial infarction. Moving on to the second part of our presentation, we're going to be talking about the methods and how we can use hospital discharge databases to build a study cohort and then conduct statistical analysis. So we have 4 bins over here. First, we're going to be building our study cohort, then having a look at radiation exposure, looking at the development of cancer, and finally, conducting statistical analysis. Looking at the first incident over here, we used the hospital discharge summary database, MedEcho, and linked it to RANQ. Using these 2 Quebec databases, which contain information on all hospital admissions in the province, we included patients who were admitted to the hospital with acute myocardial infarction between April 1st, 1996 and March 31st, 2006. Patients were then excluded based on evidence of prior diagnosis of cancer, which included admission to the hospital with a primary diagnosis of cancer, a non-cancer related admission with cancer as a secondary diagnosis, any outpatient visit with the diagnosis of cancer, or any visit to the oncologist regardless of the diagnosis that they received. The final cohort comprised of 82,861 patients. Patients were then divided into 5 groups, according to the level of exposure that they received. So first we had the control group, then we had the group of 0 to 10 millisieverts to about 30 millisieverts of low-dose ionizing radiation. So follow-up incidents for cancer began a minimum of 1 year after acute myocardial infarction, and this timeline was essential for us as it minimized the risk of association between low-dose ionizing radiation and decreased the risk of workup bias. Since sensitivity analyses were performed to explore different time lags between exposure to low-dose ionizing radiation to ensure that the incident cancers were not occurring too soon after myocardial infarction or exposure to radiation. So then after a minimum of 1 year and a mean of 5 years, a patient was considered to have cancer if at least one of the diagnostic code for cancers was met. It was also important to determine a lack of bias in the study. And so during the results, before 12,020 incident cancers were detected during the follow-up period, we looked at the general makeup of the study. As seen in this graph, there was very few differences between the age of each of the groups of the study. With the control group having a median age of 72.2 and the groups exposed to low-dose ionizing radiation having a similar mean. Majority of the participants in the study were also men, with 31.7% being women. There were also slightly less men in the control group at 59.5%. but more men in the group were exposed to radiation, so patients with higher level of exposure tended to be younger male with fewer comorbidities. It was also important to account for medical background history, to account for a lack of bias. For example, if a person had a prior diagnosis of diabetes, it led to a higher risk of cancer. Over here, it was seen that patients all had matching characteristics with the control group. Moving on to the fifth number, it was also important to note the amount of low-dose ionizing radiation for non-cardiac procedures was similar in each group before beginning experimentation to account for a lack of bias. The control group was 1.26 millisieverts. The groups with higher radiation from cardiac procedures also had larger values of radiation from non-cardiac procedures. For example, as you can see, from the 0 to 10 level, had an exposure of 1.94, while the control group was quite lower. During the results, as mentioned before, it was found that 12,020 incident cancers were detected during the follow-up period. Directly to this figure over here, so we adjusted hazard ratio for numerous things including age, sex, and exposure to low-dose ionizing radiation from non-cardiac imaging to account for the workup of cancer. Having a closer look at this graph, it shows that an increased risk leads to an increased risk is above 1 and a decreased risk is below 1 with the variables on the left-hand corner. This study shows that men have a hazard ratio 1.504. This is relatively high, with age being at 1.045. More importantly, this table also summarizes the hazard risk of radiation from cardiac procedures. As seen over here, cardiac radiation at 10 millisieverts is relatively low, but it steadily increases as cardiac radiation levels also increase, ending up at about 0.119. On the other hand, radiation from non-cardiac procedures has a slightly lower hazard ratio at about 1.008, which was quite lower than radiation from cardiac procedures. It was also important to determine the frequency distribution of the 12,020 incident cancers that were detected by site of cancer. So it's interesting that abdomen and pelvis were at 41.9%. The percentage of incident cancers at thorax was about 26.8%. Head and neck were at 9%. Bone, soft tissue, and skin were at 22%. And hematological were at 8.2%. This is interesting because looking at this image over here, it displays the procedures and the percent low-dose ionizing radiation from cardiac imaging per procedure, with percutaneous coronary intervention having the highest percentage of low-dose ionizing radiation. Since these procedures are localized in the abdomen and thorax area, and the abdomen and thorax area had the highest percentage of localized cancer sites, it concluded that cancer risk was related to the following cardiac procedures. During the final part of our presentation, we're going to be discussing that high levels of low-dose ionizing radiation from cardiac procedures did lead to an increased risk of cancer. Therefore, for future reference, it is important to be wary and understand the risks of imaging tests before conducting them, as well as properly documenting and referencing imaging tests in regards to safety.